healthy child who presented to us with an acute onset of slurring of speech, which had progressed to mutism, and she had a staring look with a preoccupied attitude. She had episodes of aggressive behavior involving those hitting her nature. She had a labile moods, and the parents said she had bouts of smiling to self and she was crying at times. And this was all associated with increased sleeplessness. So here we have a child who had a stuporous presentation with episodes of aggressive breakouts and labile mood and insomnia. Starting from her birth history, the antenatal, natal, and postnatal period were all uneventful. She was immunized up to age appropriately as per the National Immunization Schedule. Developmentally, this was a normal child. She was going to school, she was in her 11th grade and had a good scholastic performance prior to this, and she had no history of previous such episodes or hospitalizations. Her menstrual history was consisted of regular periods since menarche. And the socioeconomic history, they were from a village in Thiruvalluvar district, and the father was a daily wage laborer, while the mother was a stay-at-home spouse. This child, on examination, had tachycardia, was otherwise vitally stable. On head-to-toe examination, there were no neurocutaneous markers that we could make out. Erythematous papules were over the chest and face, and she was an overweight child with a BMI of 24.4. She had a staring gaze, a stuporous presentation, I said, and she exhibited immobility, a kind of waxy flexibility, and increased involuntary movements, some of them being oromotor dyskinesia, and she had a motor aphasia. She was not responding to our queries or questions. On further examination, her central nervous system examination was normal. Her cranial nerves were normal. Bilateral pupils were reacting to light. She had a normal motor system examination. Deep tendon reflexes were not elicitable at this point. Plantars were bilaterally extensor. The cerebral examination was normal. And the detailed examination of the cardiovascular, respiratory, and the abdominal systems yielded no significant findings. So this was a child who had a stuporous presentation with a staring gaze, a preoccupied attitude, with mutism, with insomnia, and involuntary movements with oromotor dyskinesias, all of which constitutes the myriad of catatonia. So this child outside had received ox, carbazepine, clobazam, and fluoxetine. Outside the MRI and EEG done were reported as normal. On probing for past and family history, there was no such episodes in the past, and the family also had no such similar events. So what would be our differentials at this point? So we can consider this catatonic presentation to be due to secondary to psychiatric causes, which include primary psychotic disorders, mood disorders, or due to trauma. There could be toxic and drug-induced causes, which include not all, but antiretroviral drugs, insulin, lithium being some, and drugs, of course, ecstasy and phencyclidine are some. There could be infectious or autoimmune in etiology, which could be due to HIV-associated conditions. It could be Lyme's, or it could be an autoimmune encephalitis. It could be degenerative conditions, including Huntington's, SSP. Some of the congenital metabolic disorders are Niemann-Pick's, Tay-Sachs, and further, this could be a neurosurgical tumor or an arachnoid cyst or a venous thrombosis, Dandy Walker, that could present with such a presentation. Moving forward, we evaluated the child after admitting her. The blood investigations, the renal profile was normal, the serum electrolytes were normal, our thyroid profile was normal. We did an MRI brain and a whole body to rule out any underlying tumors or masses, which was also normal. So we hospitalized the child, we evaluated her. We obtained a psychiatric opinion because of said aggressive episodes, agitation. We added lorazepam for the same. On further probing of history, there was an event that suggested that there was a generalized seizure episode. And when we could observe her, we also found there were seizure episodes involved here. So coming to our differentials, at this point, we had psychiatric was not one of our main differentials because we had ruled out, and this was more of an organic base that we had to find out. On further probing the family for history of drug abuse or risk of toxins, there was none that we could find out, so this became less likely. Degenerative conditions, congenital metabolic disorders, or tumors were all less likely as the MRI was normal, the blood picture was all normal. And this was pointing towards a more probably infectious etiology at this point or an autoimmune etiology. So to summarize, this was an adolescent girl who came to us who had initially slurring of speech, oromotor dyskinesia, and violent behavior. This went on to become associated with sleeplessness, aggression, and the slurring progress to even mutism. She had an episode of generalized tonic-clonic seizures and increased withdrawal, the involuntary movements increased, and there was a decrease in GCS. So, oromotor dyskinesia in this child presented like this. Constant oromotor dyskinesia. She had some fling. All of this was presentation. Moving forward, an EEG was done, and this showed slow diffuse waves in the background. There were no delta brush modes of the EEG. Investigations wise, we went ahead to do any underlying infectious causes. We did the lumbar puncture. The lumbar puncture biochemistry was normal. The cell count cytology was also normal. The cultures showed no growth, and ammonia and lactate done was also normal. So now, at this point, when infectious also became less likely on our differential, what next? There were unexplained neuropsychiatric manifestations. She had abnormal movements. The MRI was normal. The EEG showed a diffuse slowing in the background. The CSF cell counts, analysis, cytology was all normal. And now we suspected an underlying autoimmune etiology. We thought we'd send the CSF for N-methyldeaspartate receptor antibodies. And the CSF was positive for the anti-NMDA antibodies. So now we have a diagnosis. So this was an anti-NMDA receptor autoimmune encephalitis that initially presented with just catatonia. Later, it's evolving into a classical seropositive autoimmune encephalitis. So now the course of treatment. As we started immunotherapy, we gave her methylprednisolone and gave her IV immunoglobulins, a 3-day course, 50 grams per kg. So she got better, the involuntary movements decreased, and her speech improved with therapy, and we sent her home on levetiracetam and low steroids. However, despite this, she did not recover. And in 2 weeks, she came back to us. So now she was back in the emergency room with episodes of seizures. At this point, she could not walk or sit by herself, and her agitation, her oromotor dyskinesias, her other involuntary movements had increased. She was not responding to commands. She was her presentation GCS was 10/15 with opening her eyes only to pain. Her verbal response was incomprehensible, and her movements were only localizing to pain. In view of the severe agitation, aggressive behavior, we added diazepam, and we thought of second-line therapy with rituximab for the encephalitis. So when she presented to the ER, this was how she was. He had severe agitation. She had to be restrained. At this point, our treatment started as we had already given her IV immunoglobulins and methylprednisolone, and she showed some mild or literally no response, after which the disease started progressing again. So now we consider rituximab. We gave her the first dose of rituximab, after which still she was hospitalized. Her GCS was similar. Her clinical condition was not showing much of a change, and we were patient. We went on with the second dose, and it was only through this, the course of hospitalization after this, that we could note a plateauing of the disease progression. And after the complete course of rituximab, we could finally see some decrease in the clinical condition, and her negativism improved. We did a whole body positron emission tomography to rule out any underlying paraneoplastic syndromes, which could be the cause for this anti-NMDA encephalitis in this child. So this was the PET whole body, which we can see there's normal fluorodeoxyglucose activity. The axial skeleton was normal. The breasts and the abdomen are all normal. The PET brain showed in this PET brain, we can see that the green hypometabolic areas where the FDG metabolism is decreased. This is a classical feature of anti-NMDA encephalitis, where bilaterally there is hypometabolic areas in our occipital zone. Treatment. So now this child received first-line immunotherapy with IV immunoglobulins and methylprednisolone, then went on to receive rituximab dosage as per therapy, and her CD19 levels, as what we wanted was less than 1%, and she was on levetiracetam, initially lorazepam, and diazepam. So rehabilitation. This child needed a prolonged hospital stay. She was given, the family needed clinical psychological counseling. She needed a lot of support. Involved intensive limb therapy, physiotherapy, because there was a long period of time for which she was immobile. Her waxy flexibility was persisting. And she received speech therapy, and which she later on would approve. Due to the prolonged hospitalization, she required and immobility, she required catheterization, which led to a nosocomial UTI. And while being on steroids, she had to be treated for the same. And there were feeding issues. Initially, her swallowing was poor. She was not taking. So for a 16-year-old child, we were managing her feeds as per liquid feeds through RT and all this. So now the same child who presented to us before discharge, now after the rituximab therapy, was responding to commands. She was able to sit and walk with support, all of this with intensive physiotherapy. The feeding tube was removed eventually. Her urinary catheter was removed, and she was on oral feeds. She was tolerating them well, and she started responding to questions and talking normally. Challenges. This case had a lot of challenges. They were from a poor socioeconomic background, and a crowdfunding of 2 lakhs was arranged for the treatment, which required IV immunoglobulin initially and then rituximab. The challenge also was that there was a slow response to therapy. We had to be extremely patient, and this required a lot of support for the mother as well, because this was an adolescent girl who had psychiatric manifestations regarding the social issues, the stigma that surrounded. She was the caretaker for the child, and we had to provide the clinical psychological counseling for the family and the child. And all of this amidst the second COVID wave, the peak of the second COVID wave, during which they required prolonged hospital stay and treatment. Now, the child is on follow-up with us. Her steroids have been tapered, and she's now on low-dose steroids and levetiracetam. She's happily back in school. She's attending online classes. Her involuntary movements have reduced drastically, and since discharge, she has been seizure-free. So this was the same child who presented to us, and now she walks to us. The Cushingoid features can be noted because of the low-dose steroid she's received. And
நீ உன்னை பத்தி என்ன ஃபீல் பண்றேன்னு எனக்கு ஒரு சென்டென்ஸ்ல எழுதி காமி.
She said she feels extremely normal to be herself again. Currently, now our follow-up care for the patient will be an annual tumor screening, which we'll be carrying out, and rehabilitative measures for speech, which has now improved. Summarize, this was an autoimmune catatonia. So catatonia is a psychomotor disorder which will involve
the time
super posturing and echo phenomena. The immune system is associated with the activation of it. Mutism, withdrawal.
I think time is over.
Actually, the common
doctor, excuse me, the time.
NMDA encephalitis, which can account for the full spectrum.
Okay.
The time.
Okay, so this is a case report. It was a 16-year-old girl with severe psychiatric manifestations with solely malignant catatonia and autonomic instability. There's need for increased awareness. It was in the outpatient department. The NMDA encephalitis may present solely with psychomotor features. This was another case that we done in which 41 of these patients had immobility, staring, mutism, and posturing. So my take-home message would be, we have to put all organic causes before we consider a psychiatric diagnosis, and that autoimmune encephalitis can present solely with psychiatric manifestations. I'd like to acknowledge the Department of Pediatrics, our intensive care team, psychiatry team, nuclear medicine, radiology, our pediatric nephrologist, our rehabilitation team involving all the physiotherapists, speech therapists, and a crowdfunding agency for the same.